Assalamu alaikum. Our subject today is the drug treatment of tuberculosis. As you know, tuberculosis is an old new drug, is an old new disease. It used to be a disease of the low socio-economic status, and it is still actually nowadays. But fortunately or unfortunately, it started to appear in the high socio-economic countries as well as cities. As you know, this is due to the incidence or the high incidence of AIDS virus in the HIV virus and the syndrome of acquired immune deficiency syndrome, which appeared in the high economic status countries like the United States, and specifically tuberculosis was an endemic disease, as we mentioned, of the low socioeconomic countries, but it appeared as an outbreak in New York City. You know, New York City is maybe the largest city in the world and the most modern city in the world. But just immediately after the discovery of the AIDS problem in the United States. And it is not only that it is occurring in the high socioeconomic status countries and cities, but newer or new strains which are not sensitive to the commonly used anti-tuberculosis drugs. So we have two problems that the incidence can occur in anywhere in the world, and secondly, we can expect or we should expect resistance to tuberculosis for tuberculosis microbe of the to the antimicrobials which are used or which are used to be used in the treatment of tuberculosis. Globally, there are 9 million new cases of tuberculosis, and tuberculosis was vanishing from all the world, but now it is becoming back. It is coming back, and it is a killing disease. It can kill actually, or it killed 1.7 million people worldwide in the 2006. And TB elimination is a global health problem, and March 24th is the World TB Day. There are many problems with the treatment of tuberculosis. The drugs are special drugs. Firstly, the first problem that TB drugs are special drugs, and you will notice why these drugs are special drugs, not like ordinary antimicrobials. You know, tuberculosis is should be considered as a microbe or a bacteria, Mycobacterium tuberculi, but it is a special bacterium. You know, it grows intracellularly. It causes a chronic disease. It causes a chronic disease which has special drugs, and these special drugs, they need special care and special knowledge and special art in using these drugs. Another important point about these drugs should be given in combination, and moreover, they should be given over a long period of time, not like any ordinary infection. You know, a staphylococcal or streptococcal infection can be eradicated with one single antibiotic just within a few days. Less than a week, you can eradicate a streptococcal or an ordinary bacterial infection with one antibiotic or one antimicrobial. But the treatment of tuberculosis is associated with prolonged duration of treatment. For example, if you use three and the third strange thing about the treatment of tuberculosis that you should give these drugs in combination. One single treatment is not efficient. One single treatment, one single antibiotic treatment, or one single antimicrobial treatment will result in resistance immediately, There is no cases which should be treated with single therapy. If you use a combination of three drugs, you should extend the treatment for 6 months. If you use two drugs like isoniazid and rifampin, which are the most two important drugs in the treatment of tuberculosis, you need 9 months treatment. If you use other combinations like rifampin, ethambutol, pyrazinamide, you need 6 months. If you use rifampin plus ethambutol, you need 12 months. And if you use isoniazid plus ethambutol, you need 18 months. All others need more than 24 months or 2 years. So almost we can say that the treatment of tuberculosis is a prolonged type of treatment and needs drug combinations. Anti-tuberculous agents are divided into primary or first-line drugs, as well, and the second group are the secondary or second-line drugs. The primary or first-line drugs include isoniazid, INH, isonicotinic hydrazide, rifampin, it has trade names of rifadin or rimactane, ethambutol, streptomycin, and pyrazinamide. Actually, when we talk about streptomycin, we'll see or we'll show you that it is the first anti-microbial, anti-mycobacterial drug which was discovered in 1947, and it proved to be a great discovery in the treatment of tuberculosis and a great milestone in the treatment of bacterial infection, which followed the use of penicillin in the 1941 in the treatment of streptococcal infection. Isoniazid, we talk about isoniazid or INH as the first line drug, and we will discuss it number one. This is because it is the most important drug in the treatment of tuberculosis. It is the most active drug. It is the most active drug in the treatment of tuberculosis. But again, we should use it in combination. It is a very small molecule which is water soluble, structurally related to pyridoxine. So you will appreciate after a few minutes that pyridoxine is used in the treatment of isoniazid toxicity. It is a prodrug which is activated by the KATG enzyme or receptor, which is the mycobacterial catalase peroxidase. So this mycobacterial catalase peroxidase activates isoniazid into an active drug which is effective against the mycobacteria. It blocks mycolic acid synthesis and consequently mycobacterial cell wall synthesis, leading to a bactericidal effect in growing TB cells. So it has actions which are not similar but parallel to the effects of penicillin in streptococcus or in gram-positive bacteria. So isoniazid affects the synthesis of the mycobacterial cell wall, but not the bacterial cell wall, but mycobacteria. So it is very specific to the tuberculous mycobacterium. When it is used alone, as we said, resistance is 1 in 10 to the power 6. So every 10 to the power 6 organisms, there will be one organism which is resistant. So it is known that a TB lesion usually contains more than 10 to the power 8 cells. So this means that resistance is very common, or it is a must. It is a must, and this makes treatment with single therapy with isoniazid, it makes it a failure. So it should be used in combination. If we use isoniazid in combination, usually with, let's say, with rifampicin or rifampin, the probability of resistance will be 1 in 10 to the power 6 times 10 to the power 6 to 10 to the power 6. 10 to the power 6 times 10 to the power 6. So this equals 10 to the power 12. So this will cover the lesions or the mycobacteria in a lesion, which we said the number of these cells is 10 to the power 8. Isoniazid has good pharmacokinetic properties. It is readily absorbed after oral administration, so there is no need to give it intravenously or parenterally. It is widely distributed. Even the central nervous system, it can cross the blood-brain barrier. It penetrates into the macrophages. You know, the mycobacterium is an intracellular organism, and the can be in the macrophages, so the drug can penetrate the macrophages and can kill the mycobacterium. The drug is metabolized by acetylation. You know, acetylation is done usually by the hepatic tissue, and pharmacogenetically we have two types of acetylators or patients. These could be slow acetylators and fast acetylators. So we expect in slow acetylators there will be difference between the slow acetylators and the fast acetylators. We'll see in a minute. The adverse reactions. The first adverse reaction is hepatitis. Hepatitis, which occurs in about 1%. It is characterized by anorexia, nausea, vomiting, jaundice, symptoms of hepatic disease, pain in the right hypochondrium, death, maybe death due to severe hepatitis and hepatic failure. It depends on the age, alcohol use, and pregnancy. So the higher the age or the older the age, if the patient is taking alcohol, you know, alcohol is also hepatotoxic, and pregnancy will add to the toxicity of hepatitis. Neuropathy occurs in 10 to 20% of the patients. We mean peripheral neuropathy. It is more in slow acetylators. Hepatitis is more in fast acetylators. So you know the drug is acetylated in fast acetylators. The acetylation will occur in the liver, and consequently it will affect the liver more than the slow acetylator. While the slow acetylators, the drug will have the chance to go into the nervous tissue and affect the nervous tissue, causing neuropathy, and occurs in 10 to 20%. It is also more common with malnutrition, alcoholism, diabetic patients, AIDS patients, and uremic patients with renal failure. And usually this is due to pyridoxine deficiency. You remember we mentioned that isoniazid looks like, or it is the structure is related to pyridoxine. So giving high levels or high supplements of pyridoxine or vitamin B6 will compensate for this, or may reverse the effects of peripheral neuropathy. Neurotoxicity due to entry of these drugs, of this drug, into the brain or the central nervous system can cause memory loss, psychosis, and seizures or convulsions. Hematologic, there might be also hematologic side effects on the RBCs, white BCs, platelets. It can cause tinnitus, gastrointestinal tract side effects, as well as drug interactions. Rifampin is the next important drug. Rifampin is actually, or rifampicin, used to be called rifampicin, and from its name, it is an antibiotic. It is an antibiotic which is effective against other bacteria. It is derived from a fungus which is called Streptomyces mediterraneae, the same like other antibiotics. It is effective against gram-positive and gram-negative bacteria, so it is a broad-spectrum antibiotic, as well as it is effective against tuberculosis. So it is effective against mycobacteria, enterococci, and chlamydia. Actually, this drug was misused by the clinicians, and it used to be prescribed for regular gram-positive or gram-negative infections, like sore throat, for example. You know, doctors try to bring something new for the patient. If a patient has tried penicillins or cephalosporins for a regular infection or for a mild infection, they try to give a newer agent or a strange agent, and they used to give rifampicin or rifampicin. But nowadays, at least in Jordan, rifampicin, as well as other antimycobacterial drugs, are not available in the regular pharmacy, in the outpatient pharmacies. They are available only from the Ministry of Health. So the Ministry of Health, the same thing with the, as you remember, with the anti-malarial drugs. Anti-malarial drugs as well as anti-tuberculosis drugs are only prescribed or only dispensed. They are dispensed uh, free of charge. They are free by the Ministry of Health. You know, there is a special section of the Ministry of Health which deals with the malaria and the tadarrun and so on, the rare diseases. So they give it free for all the patients if they have a documented or approved medical report from a doctor, usually from the hospitals. Rifampicin or rifampicin binds to the beta subunit of bacterial DNA-dependent RNA polymerase and therefore inhibits RNA synthesis. So rifampicin is bactericidal. It is well absorbed, given orally. It is well absorbed orally, highly bound to proteins. It is widely distributed. So it has good pharmacokinetic properties like isoniazid. And we'll show you now after a while that these pharmacokinetic properties are important in the treatment of tuberculosis as well as the treatment of any disease actually. Hepatic metabolism, the drug is metabolized in the liver and it exhibits enterohepatic recirculation. We mentioned that rifampicin could be used or was used or was misused by the physicians in various diseases. But as we said in Jordan, the use of rifampicin should be limited to the treatment of tuberculosis as well as the prophylaxis in Haemophilus influenzae meningitis or in meningococcal carrier state. So if a case of meningitis was discovered, for example, in a children's school, we can give the whole class or the whole maybe school rifampicin as a prophylactic treatment against Haemophilus influenza. You know, Haemophilus influenza is the most causative agent of meningitis in children, as well as for meningococcal carrier state. So we have patients or we have people or persons who carry the meningococcus organism in their throat, and they can spread an epidemic of meningitis. As we said, it used to be used in the treatment of staphylococcus, simple sore throat, simple staphylococcal or streptococcal sore throat or tonsillitis, for example. But nowadays, its use for staphylococcus microorganism is only in the treatment of staphylococcus osteomyelitis, as well as in valve endocarditis. Valve endocarditis could be due to staphylococcus. So in these special cases, also we can use rifampicin. So the use of rifampicin should be limited to these cases. And as we said, it was loosely used in the treatment of staphylococcal infections, but as you know, the overuse of antibiotics, of individual antibiotics, can cause the spread of resistance, and we want actually to limit the resistance to rifampin by the tuberculous microorganism. So the only method is to limit its use only for the tuberculosis. The toxicity of rifampin, it is not a very toxic drug, but it imparts harmless orange color to secretions. So the patient will complain that his tears, urine, or sweat is red. He might notice this in his urine, or might notice this in the tears or sweat when he swipes with the tissue, with the paper tissue. He will see orange color. It can cause also nephritis, rashes, hepatitis, flu-like syndrome, liver enzyme. It is a liver enzyme inducer, so it can lower the serum levels of many drugs. So it can cause drug interactions. The next drug, which is actually the first drug, is streptomycin. It was the first in its group. Streptomycin is one of the aminoglycoside antibiotics. Aminoglycosides includes streptomycin plus gentamicin, kanamycin, and many others, which are specific or mostly used in the treatment of gram-negative bacteria. And streptomycin was the first aminoglycoside antibiotic, which was discovered shortly after the discovery of penicillin. After the discovery of penicillin, there was a rush to discover antibiotics from various fungi present in the environment, from the soil, in the air. Penicillin was derived from fungus Penicillium notatum, which was grown from the air. And streptomycin was also derived, I don't know from where, but from a fungus which is in the environment. Streptomycin was the first effective drug in the treatment of tuberculosis, but so it was a primary drug in the treatment of streptomycin. And before streptomycin, the same thing with before penicillin, streptococcal infection or staphylococcal infection was treated by, I don't know how, it was treated by non-antibiotics, not antibiotics, but by simple or primitive methods. And tuberculosis before streptomycin was treated by encouraging or by improving the general condition of the patient. Look at this expression, improving the general condition of the patient. Imagine in the times before 1947, how can you improve the condition of the patient? Just maybe feeding him very well, giving him extra proteins, ensuring fresh air, for example, and I don't know how, but not specific drugs like antibiotics, like streptomycin. So streptomycin came in 1947 to start the specific antimycobacterial or specific antibiotic treatment for tuberculosis mycobacterium. And however, resistance appeared very early after the treatment of streptomycin, and they discovered, as we said, that resistance is a very important problem in the treatment of tuberculosis, and they need to give another drug. In combination to prevent the development of resistance. Otherwise, the treatment of tuberculosis is a failure. And because of the toxicity of streptomycin, it was sent back into the second line drugs, and it was put in the background. However, recently it was discovered that many strains they might not respond to regular treatment, and they respond to streptomycin. So nowadays streptomycin is brought back into the list of the primary drugs in the treatment of tuberculosis. Streptomycin, as we said, it is a regular antibiotic. It can be used against any gram-negative bacteria, but in particular, it is very useful in the treatment of plague, although plague is a very rare disease nowadays. يعني الطاعون, tularemia, brucellosis, الحمى المالطية. It is one of the effective drugs, or the few effective drugs in the treatment of brucellosis, as well as in the treatment of endocarditis. So endocarditis nowadays is usually treated with modern antibacterials or antibiotics, but it also can be used, or it can be treated with the streptomycin. As we said, streptomycin is very famous for its toxic reactions. It can cause allergy, like fever and rashes, pain after intramuscular injection. Of course, we forget, or you should know this from your introductory course, that all aminoglycoside antibiotics are given by injection. They are all given by injection. So streptomycin was used as an intramuscular injection, which has to be given every day for a long period of time. So compliance of the patient was very poor. Compliance of the patients was very poor, and that's why the treatment of tuberculosis patients should be, or it was a must that tuberculosis patients should be hospitalized for the starting as well as for the maintenance of streptomycin injections. So you cannot rely on the patient to come every day for injection of streptomycin. So the patients have to be hospitalized to increase the compliance of the patient, and the patient should be under direct supervision to also to ensure compliance, as well as to look for or to monitor the side effects. The side effects, the other important side effect, is vestibular toxicity. Vestibular toxicity. So it is, let's say, eighth cranial nerve toxicity. It affects the vestibular system more than auditory system. And this vestibular toxicity is irreversible. So when the patient stops the treatment, he will continue complaining of the vestibular toxicity. So streptomycin is nowadays becoming back, as we said, in spite of its toxicity, and it is a very effective drug. The secondary or second-line drugs include ethionamide, capromycin, cycloserine, para-aminosalicylic acid. Para-aminosalicylic acid was a primary drug together with streptomycin, and we'll talk about the problems with the para-aminosalicylic acid. Amikacin, fluoroquinolones, linezolid, rifabutine, rifapentine. We'll try to cover these also. So what are the indications? Why we use secondary line drugs or second line drugs? The indications are first, resistant to first line drugs. So we should use the first line drugs first, and if resistance develops, we can resort to the second line drugs. Second indication is the failure of clinical response to conventional therapy. So of course, resistance occurs after success of the success of the treatment, and then there will be intikasa, or reversal of the clinical response, and the reappearance of the lesions of tuberculosis, or this clinical response could not be achieved from the first exposure to the first line drugs. Or the second or the third indication is the occurrence of serious treatment limiting adverse drug reactions. So toxic effects of the first line drugs which are not tolerable by the patients is another indication for the second line drugs. Actually, this might not be an indication, but it is the fourth point. It is a condition. It is a condition. If there is no expert guidance is available to deal with the toxic effects to second line drugs, these second line drugs should not be used. So if there is expert guidance or clinical experience with the medical term or the medical team, yes, they can handle these drugs and handle the problems which will occur after using these second line drugs. Second line drugs means or does not mean that they are safer drugs, but uh, they might be more effective or might, as we said, يعني, an alternative if we face resistance to the first line drugs. But they are toxic. Second line drugs are also toxic, but their toxicity maybe could be dealt with by expert hands. The ethionamide is a second line drug. It is related to isoniazid. Again, it blocks mycolic acid synthesis like isoniazid. It is given orally with good distribution, uh, but it is poorly tolerated. It is maybe more toxic than isoniazid. But if the patient cannot tolerate the isoniazid, we can shift to ethionamide. Maybe he will tolerate this. It depends, as you know, the occurrence of side effect depends on the patient. It can cause severe GIT irritation. This could be dealt with. That's why we say we need expert hands. It can cause neurotoxicity and hepatotoxicity. Capryomycin, it is a peptide protein synthesis inhibitor. It is injectable. It should be given by injection. It is nephrotoxic, ototoxic, and can cause local pain and sterile abscess at the site of injection. Cycloserine is another antibiotic which inhibits cell wall synthesis. It can cause peripheral neuropathy and CNS toxicity, including depression and psychotic reactions. You will notice that we'll be talking about many side effects, but maybe it is not to memorize these side effects, but to appreciate that these second line drugs have side effects which are different than the side effects of the first line drugs and maybe can be dealt with expert hands. Look at this drug. It is para-amino-salicylic acid. It has a long name and it is a very weak drug. It is a very weak drug, and it used to be used in combination with streptomycin. It is a folate synthesis antagonist. So you know para-amino salicylic acid or para-folate synthesis antagonist. It looks like a sulfa drug. You know sulfa drugs are weak antimicrobial agents. PAS or para-amino salicylic acid is well absorbed from the gastrointestinal tract, but it is, as we said, it has low potency. So the dose, look at this dose, the daily dose is 10 to 12 grams per day. This is a too large dose to be tolerated by a patient. So the patient would have a bag of medicines, maybe if you give him the medicine for a month with para-amino salicylic acid, if you multiply 12 grams per day times 30 days, this makes it a very heavy load for the patient. So he has to repeat the doses. Of course, they are not given in one dose. The dose should be divided. So again, this will reduce the compliance of the patient. The same happens actually with the streptomycin injection. It should be given every day, and it is painful. So this drug is too much to take every day in many or 2 or 3 times a day. It is widely distributed after administration, but it does not cross the central nervous system. You know, TB can happen in the CNS, and we need drugs. Sometimes we need drugs which can cross the blood-brain barrier. It is excreted in the urine. It can cause gastrointestinal toxicity, hypersensitivity reactions, and crystalluria. The same thing with the sulfa drugs. It can cause crystalluria. Of course, crystalluria can result in stones or kidney stones. Amikacin, this is another aminoglycoside antibiotic related to streptomycin and gentamicin. Uh, it is used in multi-drug resistant strains. So sometimes we are encountered or atypical mycobacterium. In many occasions, uh, a TB lesion is usually, or the patient with pulmonary TB is diagnosed or immediately diagnosed or very rapidly could be rapidly diagnosed by the discovery of the acid fast bacilli in his sputum. But the results of the culture and the specimen of his sputum is usually cultured, and the culture will take a very long time, and the culture results will show the culture sensitivity or the strain sensitivity. It might the results of the laboratory will report that this strain is a multi-drug resistant, or it is a typical mycobacterium. So in this condition, amikacin is indicated. Fluoroquinolones, these are widely used nowadays. Ciprofloxacin, levofloxacin. These are synthetic compounds. They are not antibiotics. They are chemotherapeutic agents and widely used in the treatment of pulmonary infection, urinary tract infection, and so on. But they are also fluoroquinolones can be used as a secondary line drug if resistance to the first line drug or toxicity is intolerable by the patients. So fluoroquinolones are important addition to the treatment of tuberculosis. However, the resistance develops rapidly if used alone. So again, they should be used in combination. Linezolid is also used in multi-drug resistant strains. It can cause bone marrow suppression, as well as irreversible peripheral and optic neuropathy. So it is a drug of last resort. Rifabutin and rifapentine, which are related to rifampin, they inhibit bacterial RNA polymerase. Both, like rifampin, are inducers for cytochrome P450 enzymes, but rifabutin is less potent inducer. So this might be the indication for rifabutin instead of rifampin. So if there was a problem with the rifampin being an inducer for cytochrome P450 enzymes, so maybe it caused interactions with the drugs, with other drugs which the patient is taking. So we can revert to rifabutin as a second line because it will produce less induction of the cytochrome P450 enzymes, and consequently, it is a second line drug. Actually, this interaction is very important. When the patient is an AIDS patient. We know is AIDS patient as well as a tuberculosis patient. So rifabutin is indicated in place of rifampin in the treatment of TB in HIV infected patients receiving protease inhibitors or non-nucleoside reverse transcriptase inhibitors like efavirenz. So this drug is very important in the treatment of HIV. So if it happens that the patient has TB also, I think it is not logic to use rifampin because surely there will be the drug-drug interaction and the effects of the protease inhibitors or the non-nucleoside reverse transcriptase inhibitors will be reduced because rifampin will induce the metabolism of these drugs. Uh, so far, we have to talk about a few words about the atypical mycobacteria, atypical mycobacterial, or sometimes called the non-tuberculous mycobacteria. Non-tuberculous mycobacteria. These account for 10% of the clinical isolates, as we said, after culturing of the sputum or the specimen from the tuberculous lesion. Of course, these bacteria or mycobacteria have distinctive laboratory characteristics. So in the microbiology lab, they can characterize and confirm and diagnose atypical mycobacteria after applying several tests and ensuring that this is not typical mycobacterium. It is not Mycobacterium tuberculi, but it is atypical mycobacteria. These are, as we said, are present in the environment and constitute 10% of the isolates. It is not communicable from person to person. This is good. So it is less, but however, but they are less susceptible to drugs. So this type of mycobacteria is less susceptible to drugs and needs, as we said, special drugs for their eradication. These include Mycobacterium tuberculosis complex and Mycobacterium avium complex. And the drugs which are effective in Mycobacterium tuberculosis complex include erythromycin, sulfonamides, and tetracycline. You know, these are regular antibiotics which could be used for the simple bacterial infections, but they are fortunately they are effective in atypical mycobacteria, and the regular drugs might not be effective. For Mycobacterium avium complex, it is an important and common cause of disseminated tuberculosis in late stages of AIDS. You know, tuberculosis could be localized or disseminated, or sometimes called miliary TB. It can go through all over the lungs, or maybe it can go to other organs, to the central nervous system, to the kidney tissue, or the GI tract. In these conditions, azithromycin or clarithromycin are effective, but also should be given in combination with ethambutol plus ciprofloxacin or fluoroquinolone. Drug-resistant tuberculosis could be monoresistant, as we said, monoresistant if the isolate is resistant to any one of the TB treatment drug. So it might happen that an infection or an isolate or a culture is found to be resistant to rifampin or to INH. So we call this monoresistant, or polyresistant, or multi-drug resistant, or extensively drug resistant. So there are many types of drug resistance. It could be mono, poly means resistant to at least any two TB drugs, but not both isoniazid and rifampin. Multi-drug resistance means resistance to at least isoniazid and rifampin, which are the two best first-line TB treatment drugs. And the extensively drug resistant, or XDR TB, it is these isolates are resistant to isoniazid and rifampin, plus resistant to any fluoroquinolone and at least one of the three injectable second-line drugs like amikacin, kanamycin, or capromycin. So we start with the first two important ones, which are INH and rifampin. If the isolate is resistant to one of isoniazid or rifampin, we call it mono. If it is resistant to both, we call it poly. If it is resistant to uh, 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 sorry, if it is resistant uh, any two TB drugs, but not isoniazid and rifampin, we call it poly resistant. And if it is resistant to both isoniazid and rifampin, we call it multi-drug. And if it is resistant to isoniazid and rifampicin plus others, we call it extensively drug resistant. Actually, annually, 9 million cases are recorded nowadays. 5% of these are multi-drug resistant tuberculosis. So we notice that multi-drug resistant is increasing actually, and unfortunately, 49% of those with extended drug-resistant TB died, compared to 19% of patients with ordinary multi-drug resistant TB. So it is not only a problem with the treatment, but it is a problem with the mortality of these cases. If we discover a case, it is not only a problem in treating these patients, but it is a problem that death is imminent or more imminent in the extended drug resistant TB as compared to multi-drug resistant or single drug resistance. Again, to emphasize the point that the treatment with tuberculosis should be extended with combinations, and the patient has to tolerate or cope with this the stress of prolonged treatment and combination treatment, and the quantity of drugs he is receiving, whether by injection or by swallowing every day, maybe in 2 or 3 occasions a day. And for resistant tuberculosis, we expect a 2-year period is required to complete the treatment. And thank you.